The following podcast is part of a certified educational activity titled All In on Biospecific Innovation, Guidance on the Present and Future of Off-the-Shelf Immunotherapy in Acute Lymphoblastic Leukemia. Access the entire activity and complete the post-test at peerview.com/VFF860. Downloadable slides and practice aids are also available.
Hello, everybody. The All In on Bispecific Innovation, Guidance on a Present and a Future of Off-the-Shelf Immunotherapy in Acute Lymphoblastic Leukemia. My name is Elias Jabour. I'm joined today by my friend and colleague, Dr. Aldos from California. So bispecific, we're witnessing a wave of innovation in ALL. The outcome has drastically changed due to several compounds we have available. Since 2014, we had the first approval of blinatumomab, which is a bispecific engager in refractory ALL. Then it was followed by several compounds, among them antibody-drug conjugates, such as inotuzumab ozogamicin, targeting CD22. Same year in 2017, we had the first approval of Tisacel CAR T cells for refractory ALL in pediatric and young adults. That was followed by blinatumomab approval for not only refractory disease, but MRD as well, and we will discuss it in more details. Few years thereafter, we had the approval of Brexucel, a CD19 CAR T cells, full approval of blinatumomab, and in 2024, we had two approvals. We had the approval of blinatumomab in a frontline setting in MRD negative, based on an E1910 trial that have shown an improvement in overall survival. And the obe-cel, the last CAR T, which is the first of CAR T targeting CD19 for refractory ALL. So constant improvement in outcome of ALL. These are data from our institution at MD Anderson in adult patients. And you can see an improvement seen from the VAD in all time. Then we use the Burkitt regimen into ALL in what we call the Hyper-C VAD. Then we added CD20 antibody to the Hyper-C VAD, what we call the Hyper-C VAD-R or Hyper-C VAD-ofatumumab, with a survival at 5 years of 50 to 60%. In the last 10 years, we've added the blinatumomab, the inotuzumab to our Hyper-C VAD regimen. And with the integration of immunotherapy up front, we've seen an improvement in overall survival. Today, with a maturing follow-up, we have a survival at 5 years surpassing 70 to 80%. Unfortunately, the older ALL, they don't have the same success we've seen in younger adults. And these are Medicare data among 1,428 elderly ALL patients. And sadly, we can see here that around 47% of the patients do not receive any therapy within 90 days. And what is offered is often palliation. Why is that? Because older patients usually have a very poor disease, more aggressive disease, with a lot of hypodiploidy, P50 clone present up front that cause more refractoriness to standard chemotherapy. And then, of course, they have organ damage, and that makes their tolerance to chemotherapy quite poor. For these two reasons, the outcome of ALL in all the population has been dismal. And today, with the novel immunotherapy options available to us, I think we can overcome the poor outcome of these patients, deliver something effective and not toxic, and as such, improve the outcome. So what are the goals for today's meeting? Is to improve your understanding of the mechanism of action, safety and efficacy profiles of the current and emerging bispecific antibodies in ALL. And in the next week, we'll have a meeting in Europe, in Milan, the European Hematology Association, where we're discussing novel agents as well. Have you planned personalized treatment protocol that feature bispecific antibodies in the ALL setting and provide you with guidance on practical considerations associated with the use of bispecific antibodies in ALL. So my name is Elias Jabour, and the first part of my talk, my presentation today will be done by me. Personalized standards in ALL, the role of bispecific in general, and we'll focus more on approved agents such as blinatumomab. So today, a B cell has a characteristic that is very specific to the cell. It expresses what he called epitopes, quite specific for the B cell perinormal cells. Among them, CD19, which is universally expressed on a B cell from the early stage, what he called pro-B, to the mature B cells and the plasma cells. CD22 is expressed as well in the cytoplasm of the immature cells and the surface of more mature cells. CD20 is shown to be as well expressed. And we were fortunate to have agents that can target these epitopes, can lead to some efficacy and improvement in outcome of ALL. We've used rituximab in the old days in a frontline in combination with chemotherapy. Alone, it doesn't work. CD22, we have what they call the antibody drug conjugate, inotuzumab ozogamicin, with a toxin called calicheamicin that is bound to CD22 epitope, internalized and kill the cells. And CD19, another epitope reverse expressed, where we can go after it with the immunotherapy, be it passive or active. And by passive, I mean off-the-shelf immunotherapy, mainly bispecific antibodies. So here the blinatumomab, how does it work? It's an antibody with dual arm, targeting CD3 on a T cell and CD19 on a B cell or the tumor cells. This antibody will go and attach to the T cell on CD3, activate the T cell, bring it to kill the B cell of what is called cytotoxic death of the cells. So it's an antibody with dual arm that activates the B cell, the T cell to kill the B cells one at a time. This is very innovative, and that was the first drug, first immunotherapy of this nature used in B cell ALL. We call it bispecific T cell engaging antibody. Now here I would like to show you that these drugs were first used in a refractory setting and then into the frontline setting, an MRD in a frontline setting, but today they are integrated in a frontline setting. And I show you some results from MD Anderson of we stand today. For example, in Burkitt leukemias, we're adding rituximab to chemotherapy being the hyper-CVAD or the EPOC regimen. It has shown an improvement in outcome. And today with this regimen, we have a 4 to 5 year survival of 60 to 80%. Of course, 60% in older people, younger, we have a better outcome. In the PH-positive ALL, we were able to spare the need for chemotherapy by using blinatumomab, for example, and TKIs. And today we walked away from intensive approach to transplant to immunotherapy TKI-based approach with a survival at 4 to 5 years of 75%. In the pre-BALL, and I will show you the data, we have full integration of immunotherapy up front, and that translated into improvement in overall survival. It can be used after hyper-CVAD backbone in younger patient or even a pediatric regimen or a mini-CVD or low-intensity regimen in older adults. And we've seen improvement in outcome in a younger adult. We have an 80% survival and more at 5 years. In older adults, we are surpassing 50% at 5 years. Now, for the T-cell ALL, unfortunately, we don't have the immunotherapy platform, although novel strategies are being assessed. And for example, we're exploring CD7 CAR T cells for the T cells, but these are not yet available for frontline, and they're being explored in a refractory setting. Nonetheless, in a T-cell ALL, we've seen improvement in outcome as well, and our survival is surpassing 60%. With the integration of immunotherapy up front, we're using less and less of transplant up front, and today transplant is being reserved for the PH-like ALL with some bad features, CRF2 JAK2 variant. For the high-risk karyotype with the low hypodiploidy, KM2 disease. For those with the PH positive having a lack of MRD and having IKZF1 deletion plus genotype, ATP-ALL, and finally, in a setting of MRD, if we were able to eradicate it by NGS by using blinatumomab. In all the management of AL today, it's very, very important to assess for MRD, and we have really good tools to tackle these questions today and tailor therapy accordingly. So today, where does bispecific antibodies fit in our arsenal of treatment of ALL? And these are based on approval and NCCN guidelines. Today, blinatumomab is approved and can be used in a consolidation fashion in frontline setting in MRD negative patients. Blinatumomab has a label as well for MRD positive disease to eradicate minimal disease and transform it into MRD negativity. And of course, it remains a good standard of care for patients with relapsed refractory disease, be it Ph negative or Ph positive ALL. Speaking of MRD, I think in 2025 today, there's no way we can treat acute lymphoblastic leukemia without assessing for what is called measurable residual disease, evaluated, and tailor therapy accordingly. So today, if you give steroid to anybody in the front line or minimal chemotherapy, patient can go into remission. So inducing a remission is not a big deal. However, despite this remission, patients do relapse. They do relapse because there's something minimal or measurable that we do not see present. So a remission is defined by less than 5% of blast. Everything below the 5% of blast is called minimal disease or measurable disease. And if we leave it there, the patient will relapse. Therefore, in order to prevent relapses, in order to provide a durable remission, we need not only to induce a CR, but to induce a CR with MRD negativity. And today, we have several tools to assess for MRD, and that reflects the depth of the response. We have the flow cytometry that can tackle the aberrant immune phenotype by flow cytometry. We are at 10 to minus 4, so it's not too deep. A PCR for immunoreceptor, receptor, T-cell receptor, or certain rearrangements such as BCR-ABL rearrangement disease, it can take us down to deep to 10 to minus 5. But we have today a universal test called next generation sequencing, where we tackle the immunoreceptor receptor on a B cell and a T-cell receptor on a T cell, and we can go to a million, we identify one cell among a million cells. And if we can get to this level of response, we very likely can tell our patient the likelihood of relapse is quite low, and we can tailor therapy accordingly. So the MRD assessment are reflected in the NCCN guidelines. We must assess for MRD at the end of induction, be it 4 weeks or longer. In my practice, assess MRD every month till I get into MRD negativity. We must assess for MRD at the end of consolidation and during maintenance. And every time we see any suspicion for relapse, we must intervene and have a frequent monitoring of MRD, because if we intervene at this level, we can really further improve the outcome. Waiting for the relapse to intervene can lead to dramatic results, while intervening earlier with a CAR-T, with a bispecific, will lead us to a better results. So blinatumomab was assessed first in a Tower trial, which was a randomized trial in patients with refractory disease, Ph negative in this setting, which were randomized to either standard of care or blinatumomab. Blinatumomab was shown to improve responses and improve overall survival, as shown here, from 4 months to 7.7 months. It's a randomized study, globally run, that led to the approval of blinatumomab in the refractory setting. Of course, the use of blina was better in a first salvage than a multiple and salvage 2 and beyond. Nonetheless, this drug was approved, and based on this, we further explored the use of blina in a frontline and in other contexts. Blinatumomab was approved as well in 2018 for MRD positive disease. What we have learned with the bispecific, they were more effective if given in minimal disease setting or no disease. In a BLAST trial, was single-arm, multi-center trial for which with MRD at 10 to minus 3 were offered blinatumomab. The primary point was how many can convert to MRD negativity, and of course, long-term outcome. 78% were able to convert into MRD negativity. What that means, in fact, historically, MRD positive patient had a poor survival. In fact, there's nothing called minimal, it's immeasurable, because any disease comes with a relapse. So 12 months median survival in MRD responding with a 5-year survival of 50%. So there was no randomized trial, but the median survival was 36.5 months, triple what you can see in patients who were MRD positive without the blinatumomab. Based on this data, the drug was approved in 2018 for MRD positive setting. And finally, last year, after many years of investigation, we had the result of the E1910 trial, which was a big cooperative randomized phase 3 trial, who 488 patients were screened, were induced, and then were randomized. And there are two groups of patients, MRD positive or MRD negative. Those with the MRD negative disease were randomized to either receiving their maintenance, consolidation and maintenance, or integrate 4 cycles of blinatumomab. And the results were very favorable. Those who received the blinatumomab had a better overall survival. The 3-year survival rate was 85% compared to 68% for patients who did not receive a blinatumomab. Therefore, we've seen more activity of blina and more returns if used in a frontline setting, followed by MRD, followed by refractory setting. And today, blinatumomab in a frontline is our standard of care. Now, of course, when you give a blina frontline, you do not need to give a lot of chemotherapy. In fact, in the ANCC trial, to give the full blina, there were other chemotherapy removed, and as such, the outcome was shown to be better. So how the drug is being given, and it's a drug with a short half-life. It's given continuously. In order to mitigate the complication early on, there was a step-up approach where the drug is being given at 9 micrograms per day for 1 week, with a dose escalation to 28 from week 2 and onward. The cycles were 4 weeks, given 2 weeks off, and resume the cycles. In patients who are 45 kilograms and lower, they get the dose based on a BSA, 5 micrograms per meter squared per day, which is equivalent of 9, and 28 equivalent to 15 micrograms per meter squared per day. So 14 days break. Once you get somebody on therapy and they do respond, you get cycle 2, then you go 28 from the beginning. Now, in a Tower trial, when the treatment was finished with the consolidation, patient moved to maintenance if transplant was not offered. And in this setting, patient will be given 4 weeks of treatment followed within 2 months of a period, which is a little bit different than what we give normally in ALL. In pediatric, the treatment is given 4 weeks and 1 week of break, and today we're exploring 4 weeks on and 1 week off. I'd like to highlight that next Sunday on the 15th of June at EHA, we will show the data of subcu blinatumomab. It's conceived for not only more conveniency, but more efficacy, especially the drug has shown activity in patients who are resistant to IV blinatumomab. So this drug is given daily the first week and then 3 times per week subsequent weeks. And the dose given is higher than the IV formulation with very promising results. I invite you to look at the presentation or at least read the abstract available so far online. All this with a good safety profile observed. So what adverse event we expect with this setting? As it is for bispecific, we don't see much myelosuppression, especially after the first cycle. But 2 adverse events are very specific to the bispecific engager, cytokine syndrome and neurotoxicities. 2 parts here. The CRS are seen mainly grade 1 and 2, rarely grade 3 and 4, as you can see in a Tower blast and Eco 1910, which is not the case for the CAR T cells, where CRS are seen at a higher rate. And we know as well that if we give blinatumomab in no disease or minimal disease, we have a less of a reaction. So if you introduce a blina in MRD setting or in a consolidation phase, you do not need to admit a patient to the hospital. This can be given as an outpatient. Neurotoxicity as well is seen, mainly grade 1 and 2, up to 9 to 10%. Grade 3 and 4 is in a 2 to 3% range. That being said, I think the ICANS are seen in MRD setting, in CR, and in patients with active disease. However, we do see them at a higher frequency in older people. It's very important to identify these adverse events early on because they're very manageable. For the CRS, you can hold the drug, give steroids, rarely the need of tocilizumab. But for ICANS, I think the most important thing is to hold the drug and give dexamethasone. Many in older people resume same dose or lower in older people when it's recurring events. I would say I rarely had to stop blina forever because of adverse event. It's highly manageable. So here, a scenario I actually discussed with my colleague Dr. Aldous today about a patient with a BCLL receiving frontline therapy. So Ibrahim, here Martin is a 55-year-old male diagnosed with a Ph negative BCLL, good shape, PS of 1. He received 4 cycles of hyper-CVAD, and we're assessing for MRD. And here the first scenario is assuming we have only flow, patient was called MRD negative disease. I know you're in LA, you hope you transplant a lot of people. So what shall we do for these patients? Let's say it's scenario one, we're MRD negative by flow. Are you comfortable with that? What do you do next?
Yeah, so I mean, thank you firstly, and hi everyone. For scenario one, I mean, the data support actually given blinatumomab as a consolidation after hyper-CVAD as well as after pediatric inspired regimen similar to the ECOG 1910. But again, data from MD Anderson shows actually given plina integrated with hyper-CVAD. The data is encouraging. And in this scenario, I mean, if there is no high-risk features, I mean, the treatment will be with curative intent. Hopefully, we can avoid the bone marrow transplant in these cases. So I would give blinatumomab integrated with multi-agent chemotherapy with the goal not to transplant this patient if there is no high-risk feature. For scenario two, if there is a persistent MRD, then we have blinatumomab available off the shelf and available immediately. And the complete molecular remission is really high if you give it in MRD setting, and it is well tolerated. So I would give it as well in scenario two with the intention to kind of achieve MRD negativity. But the fact that patient has MRD positivity after 4 cycles of hyper-CVAD, I would take the patient to transplant after achieving MRD negativity by blinatumomab.
This is speak for the limitation of the flow. This patient is the real case where we have a flow negative for MRD, correct? And we think it's doing great. But then, in fact, if you look deeper at the median cells, patient was MRD positive. And in fact, when you look at the concordance between flow and NGS, within around 35% of the patient being flow negative, but NGS MRD positive. And yes, definitely I agree with you completely that the blinatumomab should be the way to go. Now, here my question to you again. Let's say I give MRD positive at very minimal disease level, and I give a blinatumomab for this patient, and I measure NGS again. Patient doesn't have any bad features to start with, except the MRD, and I gave a blinatumomab, and patient became NGS MRD negative. Are you still connected to transplant, or you are happy with the blina at this stage? Of course, give more blina and maintenance and whatever you want.
So I don't think we know, Eli, because I mean, in the PLAS study, some patients who will receive blinatumomab in MRD setting, they can have actually durable remission without bone marrow transplant consolidation. But the majority in that study, actually, they end up receiving allogeneic stem cell transplant, and the risk of relapse was higher in patients who didn't receive transplant compared to no transplant. But it's very reasonable, actually, approach if the patient, let's say, has some psychosocial approach, and you're given plana in MRD disease and you're achieving NGS negative MRD, I think there is a potential of cure for some of these patients. But I mean, my practice so far hasn't changed. I still transplant these patients because they're having kind of persistent MRD after multiple cycles of chemotherapy.
We look at the specific question at MD Anderson in patients who receive a blina for MRD positive. And then, in fact, when we look at the 78% becoming MRD negative by flow or PCR, only 48% became negative by NGS. And those who became negative by NGS, means flow PCR were negative, they did not relapse or die. The survival is at 80-90% even without transplantation. In contrast, if we have MRD positive by NGS, post-blina, they do relapse and transplant is the way to go. Of course, it's single institution trial, but eventually there's a way to spare transplant. And now we have a CAR-T as well available to us that hopefully may replace transplant eventually.
So, Eli, what do you do after blina? I mean, you just stick with blina or you alternate with chemotherapy?
No, we do 4 cycles of blinatumomab, and then we move to a maintenance with pump, and we do 1 blina after every 3 pump, and I track NGS. If the NGS is negative, I will not do transplant. If NGS is positive, I'll do for CAR and discuss transplant post-CAR.
Yeah, the thing, Eli, if you look at the Jymima study recently that's published, they show that actually if you give plana after time point 2, if you have an MRD positivity, then you clear the MRD by the European PCR for MRD, which is 110 to the -5. Even that the majority of patients achieve MRD negativity, these patients continue to have high risk of relapse compared to someone who was MRD negative before blinatumomab. So, I mean, although blinatumomab can convert more patients to MRD negativity, not necessarily can improve the risk of relapse. But again, I mean, it's not NGS, which has actually more sensitive, which is a more sensitive MRD in the setting.
I think we cannot make a global statement for everybody. I think we have to associate genotype and MRD. And then even if MRD negative for bad genotype, it's not good enough. Transplant is still needed. If you have a favorable genotype, maybe MRD negative NGS, you can get away without transplantation. So what have we learned about the experience with T-cell engaging today? Immunotherapy is used for each of the cases. I think today T-cell engaging antibodies are part of the treatment paradigm in a frontline, and we have in a relapse setting. We've learned that adverse events are highly manageable. I think CRS can be managed by giving the drug at a low tumor burden, such as MRD or no disease. ICANS in older people, one should be very careful. And we've seen that with the CAR T cells as well. Still, less adverse events are seen in minimal disease. Better ICANS and older people do not do so well. The question to you, Ibrahim, if Weblina is upfront, what we have left for the second line?
Yeah, I think that's the tricky part. I mean, the nice thing, we have actually more than one CAR T cell product at this time available in case patient relapse as CD19 positive. I mean, we're hoping we're seeing less relapses really at this time as we actually integrate in plan in the frontline therapy. But for those who relapse with CD19 positive, we have the CD19 CAR T cell therapy. I think the challenge will be patient relapse with CD19 negative disease, as we have to look for other target therapy in this setting.
Okay, great. Thanks, Ibrahim, for your insights.
Great.
And with that, I'll pass the floor to my colleague and friend, Dr. Aldous, who's from the City of Hope, who will go over preparing for the future insights on newer T-cell engaging antibody strategies. Ibrahim, the floor is yours.
Thank you. Yeah, so I'm going to discuss a few points. One of them is there a rule for chemotherapy-free combination with T-cell engagers, especially in pH-positive ALL? And are there any newer bispecific with potential treatment rule for relapse refractory ALL? Eli mentioned about the sub-Q Blina, which the data looked very encouraging, especially the high response rate, including patients who failed prior blinatumomab. But the question, what else actually in the horizon? And how will blinatumomab and other bispecifics be used as part of sequential therapy? Especially now we have introducing blinatumomab frontline. We have the CAR T cell therapy. We have ADCs as part of the ALL treatment. How we can sequential these treatments? So moving to pH-positive ALL, if you look at the most recent NCCN guidelines, blinatumomab in combination with TKI as a chemotherapy-free regimen is actually recommended as a frontline treatment for both younger and older patients with newly diagnosed pH-positive ALL. And this is based on some encouraging data published by different groups, initially by the DALPA group, where they combined the dasatinib with steroid for 85 days. And after 85 days of treatment, patients received combination blinatumomab and the dasatinib. And the study shows actually very encouraging safety and response outcomes. We have seen that the complete molecular remission improved from 29% after the 3 months combination of steroid and TKI to 60% after the first 2 doses, after the first 2 cycles of blinatumomab and the dasatinib. What's more encouraging is the long-term actually follow-up outcomes for the DALPA study, where we see the 4-year overall survival is 81% and the 4-year event-free survival is 75%. And including some patients actually who didn't require any transplant and they just received blina TKI, they remain on TKI, and they have very long-term durable remission with this approach. And this is important because, I mean, pH-positive ALL is more common in middle-aged, older patients, and these patients, they tend not to tolerate chemotherapy well. In addition to that, usually pH-positive ALL tend to be a chemorefractory disease. And if you look at previous study, at the GRAIL study, where they compare high-intensity chemo plus TKI versus low-intensity chemo, just steroid, vincristine, and TKI, they show actually the response, if anything, was comparable, if not better, with the low intensity as you reduce the induction mortality with this approach. We have also the approach from MD Anderson, where they actually introduced blinatumomab and they combine it with third-generation TKI, ponatinib. Blinatumomab was started earlier in the treatment course, unlike the ALBA study, where patient was cytoreduced for 3 months before they start the blinatumomab. And the results for the ponatinib and blinatumomab study was very encouraging. I mean, the MRD negativity rate was very high, including negative NGS MRD. And again, the follow-up is shorter than the DALBA, but so far results looks very promising with few relapses. Now, the challenge with this approach has been is among the few relapses we see after chemotherapy-free approaches in Ph positive ALL is many of these relapses have been extramedullary and the CNS. And there are different approaches how we can actually mitigate this and reduce the risk of CNS relapse. Our colleagues at MD Anderson, Eli, and colleagues, they've been increasing the IT chemotherapy that is given during the chemotherapy regimens. Other groups, they have been actually introducing some kind of few cycles of intermediate dose systemic methotrexate to reduce the risk of CNS relapse. And there's currently an ongoing alliance studies comparing TKI and blinatumomab versus hypersevad and TKI in newly diagnosed Ph positive ALL. And hopefully the study will give us a definitive answer if chemotherapy-free regimen will be the standard of care for newly diagnosed Ph positive ALL. But definitely this approach is actually gaining more and more interest, and more institutions have implemented this approach as their standard of care. So typically, the frontline therapy for Ph positive ALL in adults is combination of blinatumomab, usually for 5 cycles, along with TKI that can be second or third generation. The most recent phase 3 Falcon study that was presented by Dr. Japour shows actually superior outcomes with ponatinib over imatinib as a frontline therapy. So there is more and more use of ponatinib as a frontline therapy. For patients who achieve MRD negativity by clonoSEQ, and this is important because there is high false positivity for PCR when used for MRD assessment in Ph positive. So the recommendations actually is more to use NGS because it's a more sensitive and specific MRD assessment in Ph positive compared to PCR for BCR APL. But for those who achieve MRD negativity by NGS, the recommendation is to continue maintenance TKI after completing 5 cycles of blinatumomab. There's a question, what do you do with high-risk genetic, like the IKZF deletion plus, and if these patients, if they achieve early MRD negativity by NGS, still need a need for transplant consolidation or not. Now, for patients who continue to have persistent MRD by NGS, their outcomes not as good as someone who achieve MRD negativity, and they can benefit from CAR T cell therapy. And if they achieve MRD negativity, then the question patient can go to TKI maintenance if they're not transplant eligible versus going to transplant followed by TKI maintenance. If they still NGS MRD positivity or they have MRD positivity relapse after CAR T cells, then the recommendation is to receive stem cell transplant followed by TKI maintenance in this setting. Now, what other emerging bispecifics we have in ALL? One of the most promising, actually, bispecific antibodies in ALL is the AZD0486, and there will be a presentation in EHA in patient with relapsed refractory B-cell ALL. So AZD0486 is a novel IgG4 full human CD3 CD19 bispecific T-cell engager. It has a low affinity for CD3, and this is designed uniquely to reduce cytokine release and reduce the toxicity of bispecific while maintaining the potent anti-tumor cytotoxicity. Because the design, it has a long half-life between 9 to 11 days, so that can support the dosing every 2 to 4 weeks, which is advantage over the blinatumomab that is need to be given as a continuous infusion. So AZD was explored in non-Hodgkin lymphoma initially. There are studies in follicular lymphoma and diffuse large B-cell lymphoma. And it went from fixed dose escalation to single step-up dosing to reduce the risk of CRS and toxicity, to double step-up dosing where the dose started at lower dose, then escalated on day 8. Then they reach the target dose on day 15. Then the target dose is given every 2 weeks in this setting. So in non-Hodgkin lymphoma, so the drugs show promising clinical activities in heavily pretreated patients, including patients who failed prior CAR T-cell therapy and other T-cell engager like CD20 T-cell engager. So if you look at different doses were tested in diffuse large B-cell lymphoma, including patients who had prior CAR T-cell therapy, the overall survival, the overall response rate was actually encouraging. It seems there's maybe dose-dependent improvement in response with the AZD. This can be seen in both patients who are CAR T-cell naive as well as patients who receive prior CAR T-cell therapy. And the overall toxicity was manageable. 43% of patients had CRS, but all these cases were grade 1, which was manageable. And typically, we see the toxicity early during the step-up dosing. ICANS was also occurred, but most of them were grade 1 and 2, and grade 3 was only 5% in diffuse large B-cell lymphoma. Now, this led to kind of testing AZD0486 in patients with relapsed refractory B-cell ALL. There's a study called the CIRUS study, which include dose escalation of IV AZD0486 in patients with relapsed refractory B-cell ALL. And it include patients who had prior blinatumomab and CAR T-cell therapy as well. So the study has different parts. They have the dose escalation, then after that, the dose optimization, and finally, the dose expansion. So far, we have completed the dose escalation, and we are presenting some of the dose escalation data in the coming EHA. The presentation will be on Thursday, the 13th of June in Milan, Italy. So we completed 2 dose levels. You have dose level 1, which the target dose was 2.5 milligram, and dose level 2 was 7.2 milligram. But in the oral presentation, we'll also present some data from dose level 3, which we escalate the dose to 15 milligram. But if you look at the patient characteristics in both those levels, were heavily pretreated. The median prior lines of therapy was 3 lines of therapy. You have patients had up to 9 lines of therapy. Many of these patients had prior blinatumomab or CAR T-cell therapy, or they have actually both blina and CAR T-cell therapy. And many of these patients had prior allogeneic stem cell transplant. Now, we know the correlation between response to blinatumomab and disease burden. As we see, high disease burden defined usually more than 50% bone marrow plus associated with less response to blinatumomab. We see in patient characteristics enrolled in dose level 1 and 2 that the median bone marrow blast was 69% in dose level 1 and 46% in dose level 2. So we have not seen any treatment discontinuation so far on dose level 1 and dose level 2 due to AZD0486 related adverse events. And no new safety signals were identified compared to what we have seen in the non-Hodgkin lymphoma. We have seen CRS in 31% of patients. Mainly, we see it during the step-up dosing before reaching the target dose. Usually, once you reach the target dose, having CRS and neurotoxicity was not common. So again, we see CRS, but the majority are grade 1 with few grade 2 CRS. We haven't seen any grade 3 CRS in these 2 dose levels. And we only saw 1 grade 2 ICANS in dose level 2. And so looking at the efficacy of the AZD0486 relapsed refractory B-cell, so far results are very encouraging. At dose level 1, the overall response rate was 46%. And for the patient who achieved CR/CRi, 83% achieved MRD negativity. And the durability of remission was up to 330 days at the time of the data cutoff. And for dose level 2, The response rate was 67%, and all patients who achieve CR/CRi achieve MRD negativity. Now, what differentiates AZD0486 than blinatumomab, besides it is given as an infusion every 2 weeks compared to continuous infusion, that we're seeing actually encouraging responses in patients with high disease burden. Now, among 10 patients with high disease burden defined as 50% more blast or more, 80% achieved CR/CRi. And these responses were meaningful as several patients were able to receive consolidation with allogeneic stem cell transplant. And another differentiation from blinatumomab is the activity in the extramedullary disease, something we don't see with blinatumomab. Again, the number of patients with extramedullary disease was limited to 4 patients, but 3 out of 4 of these patients actually cleared the extramedullary disease in dose level 1 and 2, but we have actually more patients in dose level 3, and hopefully we can present in the EHAB meeting. So with these encouraging results, again, I mean, the same story as blinatumomab, we see that the drug is effective in the relapse refractory setting. So then the interest is to try to move it early in the treatment paradigm, especially for patients who don't handle chemotherapy well. And what's unique about the AZD is the way we infuse it. Rather than continuous infusion, it's an every other week infusion, so make it more accessible, easy to give. So there's a plan to kind of design a study where we give the AZD0486 as a frontline therapy in newly diagnosed older adult patients with B-cell ALL. But there are other studies exploring AZD0486 in patients with non-Hodgkin lymphoma, including as a frontline study in patients with newly diagnosed follicular lymphoma. So we have a case, Elise. So this is Jennifer. She's a 28-year-old patient. She has a relapse refractory Ph negative B-cell ALL. So initially she was treated with a CLGB 10403 regimen, and this is before the approval of blinatumomab in MRD negativity. So she had an early relapse, which was CD19 positive, and she received blinatumomab as salvage. Blinatumomab was able to bring her into complete remission. Then she received allogeneic stem cell transplant as a consolidation therapy with the hope that this will cure her disease. Unfortunately, she relapsed 2 years later with CD19 positive. So the question, Lee, what will be your first choice treatment in Jennifer's case?
This is a 28-year-old patient who's relapsing post-transplant who had a blina. Of course, I have to check the immune phenotype of this patient, see if she's lymphoid or myeloid. I don't know if she's KMT2A disease or not, assuming she's not. I'd like to check her CD19 expression, CD22. At this stage, CAR-T is my approach to this patient, but before go to the CAR-T, I would like to put her in remission, get her disease under control. I'll explore clinical trial option, among them the AZD, subQ blina, whatever available to me. Assuming there's no clinical trial available, CAR-T is my way to go. I like to collect this patient for CAR-T cells, but meanwhile, I like to bridge with something to put her in remission. I use inotuzumab-based regimen, inoblina-based regimen, get her into minimal disease, and get CAR-T as a consolidation. Now the question we will debate thereafter, if I put her in remission, I can get her lymphodepletion with minimal disease status. I think the outcome with CAR-T will be by far better than giving CAR-T in full active disease. I will go with the CAR-T cells. Post CAR-T cells, I will look at the MRD status, I look at the expansion, the persistence. I may opt not to go for second transplant if I can get good remission in this setting.
So let's say that her relapse is CD19 positive and CD22 negative. And I mean, I agree with you. I think CAR is the way to go as of now because, I mean, we have most of the data that can potentially give you durable remission without a second transplant in this case. But CAR-T cells has some challenges. And let's say that her disease is proliferative disease, which sometimes creates some kind of problems of kind of planning the collection, keeping the disease under control if you don't have the intuzumab to cytoreduce. Would you consider, would you favor bispecific antibody? I mean, you're going to present the data for subQ blinatumomab, which seems to be very effective. The AZD appears to be actually effective as well in the setting. So you have the option of a study that is available immediately. You don't have to make the CAR-T cells versus kind of try to cytoreduce, control the disease without intuzumab before you go to CAR T cells.
Ibrahim, I agree with you, and I don't think there's this one or the other one. I think they're complementary. As long as the expression is positive, I would not go for CAR T cells before putting somebody in remission. This is my philosophy at Houston here. So AZD, bispecific, or Blina specific, whatever I have, I want to use right away. However, I may collect the cells before for CAR T cells just to preserve the T cell function and do my AZD series every other week, do my subQ blinatumomab, and once I get into low disease or no disease, do my CAR T consolidation. In fact, I may not need the CAR T as well. We're debating in Houston, is CAR T needed in a relapse setting if somebody is MRD negative by NGS? For example, when we did the mini-CVD Blina, we look at outcome transplant, no transplant, we did not show a difference, and mainly in MRD negative by NGS. So the question is, if you use bispecific here and you become MRD negative by NGS, you can go for a second allo transplant, it's fine. But I'm not sure CAR T is needed. I don't know. So yes, my first approach for this patient is to get off-the-shelf immunotherapy, whatever I have available to me, and then CAR T thereafter.
Yeah. Okay. I mean, what we will see, what we're gonna start seeing is actually patients who receive CAR T cell therapy at earlier actually phase of the treatment. I mean, now we're using chemo plus Blina. And again, in MD Anderson, you already have used intuzumab as a frontline therapy. So most likely, most of the CARs will be used actually at the first relapse. So I think the challenge will be is relapsing after CAR T cell therapy. And I think this is the advantage of having these other CD19 options in case the patient relapses with CD19 positive.
And here, a very important question, because we measure MRD by NGS, and I think we should not abandon flow, especially if we have immune phenotype change. So we still need a flow to look at the gating and different immune phenotyping, CD8 expression, positive or negative, that the NGS MRD does not give to us.
Thank you, Eli. So maybe we can save some time, Eli, to kind of answer some of the audience questions.
Definitely. And we have several questions here submit to us, Ibrahim. So the first question is, are you concerned about T cell exhaustion when sequencing between CD19 bispecific and CAR T cells?
I mean, there's a concern.
Same question apply for Blina and your CD19 bispecific.
I mean, there is a concern, but I mean, if you look at the data, I mean, many of the patients who received CD19 CAR T cell therapy had prior blinatumomab, and they still respond really well to CD19 CAR T cell therapy, similar to the AZD0486, and I'm sure the same thing for the subQ blinatumomab. Now, at least for Blina and CAR T cell therapy, at least with the T cell, they have seen patients, if they did not respond to Blina, these are the ones who they don't do well with the CD19 CAR T cell therapy. I don't think we have data for other CAR T cells or other bispecific as of now. But prior CD19 therapy should not preclude actually giving CD19 CAR T cells or other bispecific if the CD19 is returned.
You know, we look at the patient who received a blinatumomab and failed, and in fact, 92% of the patient retain their CD19 expression. And as such, I think that will not compromise the CAR T or subsequent bispecific to be given. Now, I know there was a concern, if you give a Blina and you give CAR T, it may not work well. I think patients who did not do well with the Blina, they have a very poor biology that made them resistant as well to subsequent CAR T cells.
Yeah, I agree. I think it's more kind of intrinsic disease biology rather than prior exposure.
We had another question. Is there a rationale for use of a Blina outside of the context for MRD when you don't have access to fast or accurate MRD assessment? I think Blina today is approved for all patients, MRD negative or positive. Of course, I encourage you to assess for MRD to get an idea whether you go for transplant or not. But I think using a Blina is not limited for MRD positive patients.
Okay, Lee, this question for you. CD19 overexpression, a requirement for using Blina and other T-cell engager in relapse refractory ALL. I'm not sure here if they're referring CD19 positive or negative or any CD19 expression make the patient eligible for CD19 target therapy.
In fact, in our protocols, we have CD19 expression positivity. We not specify a level. I would like to highlight that CD19 expressed at a very high level on all B cells. You rarely somebody with a very low level. However, in patients with a low level below 70%, often they have KMT2A range disease. and these patients respond transiently and may progress rapidly, at least in adult patients. I think if you have a low expression, check for KMT2A disease and try to refer them to a trial with Dr. Aldous or someone else with maybe menin inhibitor combination with the blinatumomab or either bispecific. And if you don't, try to go for transplant as soon as possible because relapses can be imminent here.
Yeah. Eli, there's another question, I think similar to the previous question you answered. If you are in sitting without fast MRD turnaround, how do you decide whether to start Plena empirically or wait? I mean, I think you answered this, yeah.
Yes, I will get the Blena, right? I will get MRD assessed. I will start the Blena regardless. I will get the result of the MRD and I can track it. So usually when you give a Blena, you get the response within a month. So I will get the first course of Blena. I get my MRD status. I will get the second one. I will get the result of the first one after first cycle of Blena. If after 2 cycles you're MRD positive still, you need to move on to CAR T or to transplant or somewhere else.
Yeah.
There was a question, Ibrahim, for patients with a Ph negative ALL, are there practical differences incorporating Blena into hyper-CVAD-based regimen versus E1910? I don't think anybody uses E1910 anymore. Do you?
No, we do the CLGB 10403 and we integrate 4 cycles of Plena during cycles after consolidation.
With the hyper-CVAD, we do 4 hyper-CVAD and we do 4 Blena thereafter. And we trim the maintenance from 36 months of pump to 12 course of pump with 1 Blena after every 3 pump. But this is a maintenance, it's still not confirmed by others. But our strategy is to limit the use of intensive chemotherapy and move more into immunotherapy approach. The Golden Gate 360 trial will address the question of maintenance as well, and not only induction consolidation.
Eli, this question for you, is there any rule for inotuzumab in the MRD positive setting if bispecifics are not appropriate?
Yes, we conducted a study assessing inotuzumab in MRD setting, which is 40 patients. In this cohort of patients, it was enriched with patients who failed blinatumomab. Even in this situation, inotuzumab induced responses in about 70%. The 2-year survival was 60%. I think, yes, it does work. But of course, it's single institution trial, and I think we'll see more use of INO for MRD, post a Blena failure, and I think as a bridge for a CAR T cell thereafter. Other question to you, does the quality of remission matter after blinatumomab? For example, if a patient relapses shortly after blinatumomab, are they still candidate for CD19 CAR or other CD19 bispecific, Ibrahim?
Yeah, so I mean, they are, as long as they retain the CD19 positivity. I mean, the quality of remission matter after Blena. I mean, I think if you still have any level of MRD by NGS, if low, I mean, most likely these patients will relapse. So, I mean, we're always hoping for NGS MRD negativity, but if they relapse with CD19 positivity, they can benefit from other CD19 target therapy.
Have you favored bispecific TKI chemotherapy-free treatment in older patients with PH1 given the evidence in this area? The answer is absolutely yes. Yeah. In older patients, I think intensive chemotherapy is not the way to go. Blena and TKI, be it dasatinib and the ALBA that Aldous mentioned, or Blena ponatinib from MD Anderson, the 4-year survival is surpassing 80% to 90%, and spinning it for transplant. I think this is really transformative. Ibrahim, in your practice, use Blena ponatinib in a frontline or Blena TKI?
No, we use Blena ponatinib usually, but we try to cytoreduce for 1 cycle with TKI, vincristine steroid, then we move to Blena and CR.
Okay, this question to you about AZD0486. Given the data, can you say one way or the other whether standard approach for monitoring, use of TOSI, etc., will be applicable with these agents for CRS management?
Yeah, I mean, so it's similar to any other kind of CD19 or other bispecific or CAR. If the patient develop CRS, I mean, we tend to kind of intervene early now with any of the treatment, including tocilizumab plus minus dexamethasone. We tend to use tocilizumab for grade 1, but if it is more than this, we tend to give dexamethasone. Now, this is different than blinatumomab, or blinatumomab you can turn off the infusion, especially in the setting of neurotoxicity, and give dexamethasone carriers quickly. This is long half-life bispecific, but from the experience so far, they tend to improve quickly with dexamethasone.
And is this the same with subcu blinatumomab because the half-life is a little bit longer, and you give dexamethasone and do respond so well? But I think the key is to give these drugs in somebody with a minimal disease, not to go for bulky disease and give the agents. In fact, and there's a question here, the follow-up question, if ACD is given and you have a good remission, you will use ACD as a bridge for CAR T cells or transplant?
As of now, we've been using it as a bridge to CAR T cell therapy because we don't have long-term follow-up data in relapse refractory ALL.
Okay. And then the question we answered about quantifying CD19 expression before blina. I think, yes, we always measure CD19 before blinatumomab or any bispecific targeting CD19 or CAR T cells. How often you see loss of CD19? I think in a setting of bispecific, the resistance is not driven by CD19 escape. It's more a binding story. And that for most of the patient, I will say more than 90% will keep CD19 expression, which is not the case for the CAR T cell, where half of the patient will relapse, progressing with CD19 negative disease. We call CD19 escape. So I think, yes, we must measure CD19 expression in somebody who about to receive CD19 immunotherapy, passive or active, or post-therapy failure.
Eli, let me ask this question. What are the logistical or safety considerations for giving plina or other T cell engager in the outpatient setting?
I think it's not so complicated, especially if you treat somebody with no disease or minimal disease. It can be given as an outpatient therapy. I would say the first course, somebody with active disease, do it in an inpatient setting. With the blinatumomab, for example, you fill the first week, and then from week 2 and onward, we give 1 week bag, and people will come to the ATC once a week to outpatient setting to refuel the bag and go home. I expect the same with the AZD bispecific to be the beginning to be in the hospital to mitigate all the complications. But once you establish good remission or past the first cycle, it can be given as an outpatient in a biweekly schedule.
Yeah, that's correct. So any additive toxicity when using bispecific like plina or other in combination with multi-agent chemotherapy in ALL?
Actually not, because they're not myelosuppressive, and you'll be surprised that we can combine hyper-CVAD with the blina. We can give 3-4 days of chemotherapy and give a blina from day 4 and onward. And we don't see much complication. I will still be cautious in older people. We see more ICANS in older people than younger people. But being aggressive by holding the dose, give steroid, and reducing the dose if needed, that helps mitigate this concern in a major way.
And for pH-negative patients who are progressing after being treated with plina and eno in prior LOT and are ineligible. Okay. And ineligible for transplant or CAR, what do you typically reach for as treatment?
I mean, fortunately, these patients are rare to be seen nowadays because we've not seen truly resistant patients nowadays. I mean, we do see, but not as commonly as before. And we have to consider subclinical trials being phase 1, phase 2, bispecific, BCL2, BCXL inhibitor, intensive chemotherapy, CD22 CAR or others. So we have to explore other options. We haven't cured everybody, but the cure rate observed nowadays is really amazing compared to where we were 10 years ago. So the survival of ALL has moved drastically into a major way. Ibrahim, that will bring us to the end of the session. And that was really enlightening to me. Thank you for being with me today. Thanks a lot. Thank you, Ibrahim.
Everyone, thank you, Dr. Jabbour. Take care.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/VFF860.